Good morning, everyone. Can you hear me okay? Okay, perfect. Thank you so much for coming. Thanks for allowing me to speak. It's really an honor to speak to you guys today. So today, my name is Chelsea Cook. I'm a physician assistant with Rocky Mountain Cancer Center, focusing primarily in the breast cancer setting. I have no disclosures today. So for today's presentation, we'll spend a little bit of time doing some background, talking about the impact, the epidemiology, who is affected by breast cancer, as well as the key risk factors that play into the development of breast cancer. Then we'll move into an overview of the different subtypes of breast cancer, particularly as they relate to key therapeutic options. And we'll kind of use this time to structure just sort of a high-level brief overview to sort of see how all of the different pieces fit together. And then we'll spend the bulk of our time talking about some of these newer drug therapies that I'm sure a lot of you have seen in clinical practice. And then finally, we will end with a brief overview of a few key updates from the most recent 2022 San Antonio Breast Cancer Symposium. So starting with the impact of breast cancer, why do we care about breast cancer so much? And how does it affect us? Well, it's the most common cancer worldwide, and the most common cancer diagnosed among women in the US. It's the second leading cause of cancer deaths in women in the US, second only to lung cancer. About 1 in 8 women, or 13% of women in the US, will develop invasive breast cancer in their lives. And I'll caveat that to say that's outside of an increased risk of any kind of germline genetic mutation that inherently puts someone at higher risk. In this year alone, over 300,000 women are estimated to develop breast cancer, and over 43,000 women are estimated to die from breast cancer-related causes. As you can see, the 5-year survival rate's much better if we catch it early for that localized disease. Regional disease, still pretty good at 86%, and then when we have metastatic or late-stage disease, survival rates really plummet quite significantly. Oh, wrong way, so sorry. So who gets breast cancer? Largely it's a disease of aging, so women typically older than 50 years old. However, if a woman has a first-degree relative with breast cancer, her risk nearly doubles. Still, only 5 to 10% of breast cancers typically are linked to those germline or inherited parental genetic mutations that one inherits from their parents, including common ones like BRCA1 and 2, PALB2. Typically, these will also manifest as breast cancers in younger women. Still, the vast majority of the bulk, 85% of these cancers, occur in women that don't have any family history and are more related to these somatic genetic mutations that crop up as a result of DNA damage over time, part of the natural aging process, as well as environmental and lifestyle factors. And then, unfortunately, there is a health gap disparity. Black women are much more likely to die of breast cancer than any other racial or ethnic group, but thankfully this gap has been narrowing in recent years. So what are the risk factors? We'll start with those that are modifiable, so things that you can change. Weight is one. Obesity is a big contributing factor, as it can contribute to a hyperestrogenic state, which we'll talk about a little bit later, can really lend itself to the development of a really common subtype of breast cancer, or hormone receptor positive. Alcohol use, so even moderate alcohol use, which is defined as just 1 drink per day in women, increases a woman's overall risk. And then when we increase that to a heavy alcohol use, defined as 2 to 3 or more drinks per day, that risk can go up by about 20%. Smoking, of course. Breastfeeding status, so if you fortunately have breastfed, that typically results in a lower risk. And then the use of hormone replacement therapy, or HRT. This just increases a woman's lifetime exposure to estrogen and therefore increases her risk. Activity levels, so women who are more active typically have a lower risk than women who are sedentary and do not exercise. And then nulliparity, or later onset of having children over the age of 30. And then those non-modifiable risk factors, so unfortunately, things that are outside of the realm of our control is age, as we talked about, kind of a disease of aging. So typically affects women over the age of 50. Sex, obviously, much more common in women than in men. those germline genetic mutations that we touched on earlier, particularly BRCA1 and BRCA2 with the highest penetrance. And then race and ethnicity. So again, Black women typically more commonly affected and more common to have those triple negative breast cancers. There are certain other ethnicity groups like Ashkenazi Jews that also have higher penetrance rates of BRCA1 mutations. Family history, like we touched on earlier, as well as one's personal history. So if you have a history of a precancerous lesion like a DCIS or a benign breast disorder, atypical ductal hyperplasia, that can increase your risk, as well as history of prior radiation therapy, especially if that occurred when you were quite young. Along with personal risk, the breast density. So those breasts that are more fibrous, more glandular, typically we can see a higher incidence of cancers. And we think part of this is just because of the difficulty and limitations of mammograms. So those lesions are harder to pick up on traditional mammography, and oftentimes will require breast MRI. And then age of menarche and age of menopause, again, the earlier you start menstruating and the later you stop, just leads to an increased overall lifetime exposure of estrogen. And then I, again, included viliparity just as a subtle nod to we can't always decide if we have children and at what age we have children. So we'll move into the pathology classification. So within this realm of cancer, we can have a carcinoma in situ, which is a cancer that is still contained within the duct or the lobule itself and has not spread outside of it, or we can have an invasive cancer. So within those two, a ductal carcinoma or carcinoma beginning in the duct is by far the most common, followed by lobulars. The lobular carcinomas tend to be a little bit more insidious, sneaky, aggressive, more likely to recur. And then there are obviously some other subtypes that are much less common. So as you can see on this side, I think I have a fun laser here we'll try out. So you have a normal duct here, and then we continue down along the gradation of abnormality. So you can see these cells start growing more atypically, progressing down to DCIS or ductal carcinoma in situ, where those cancerous lesions are still contained within the duct. And then once they exit that duct, that's when we now have an invasive breast cancer. So now we'll move along to the different breast cancer subtypes, including ER, PR positive, HER2 positivity. So starting with hormone receptor positive disease, this is composed by ER, estrogen receptor positive, and progesterone receptors. And these breast cancers have those receptors actually on their cell membrane, and so they'll use those hormones to grow. Typically, this is thought of as a more favorable tumor prognostic because we can use endocrine therapies to actually block those receptor sites and thereby inhibit the cancer cell's growth. These are by far the most common, about 70% of breast cancers. We'll refer back to this slide in just a moment. But the kind of two main areas that we look at for estrogen production is the production of ovarian estrogen in the premenopausal setting that can thereby act on those HR positive breast cancer cells. And then in the postmenopausal setting, we still have a good amount of estrogen that lingers around, albeit much lower than the ovarian production. And this is mainly coming from adipose tissues, adrenal glands, and the pancreas. So what are the mainstays of endocrine therapy that are so important in HR positive breast cancer? We've got 3 different subtypes, aromatase inhibitors, selective estrogen receptor modulators, and selective estrogen receptor downregulators. So AIs include letrozole and astrozole and exemestane, which I'm sure we've all seen quite often. So these drugs work on that extra ovarian conversion of estrogens by blocking that enzyme aromatase that we saw over here on the right side of this graphic. We typically use these in the postmenopausal setting unless we use them in a premenopausal woman paired with ovarian suppression like Lupron to block that left side of the graphic, that premenopausal ovarian production of estrogen. Common side effects of these drugs include things like hot flashes, night sweats. The myalgias and joint pains can be quite significant and can be quite limiting in therapy. You can also have vaginal dryness, decreased libido, mood swings, sleep disturbance, weight gain, bone mineral density. So we're kind of across the board inhibiting estrogen and kind of sending a woman deeper into menopause. And so that can damage the bones as well. And so we really want to be careful about checking regular bone density screening in these women and making sure that they're doing weight-bearing exercise, calcium, vitamin D. Then we have selective estrogen receptor modulators, or SERMs, most commonly used as tamoxifen. These are really interesting drugs, sort of a mixed agonist-antagonist picture. So these drugs will agonize or augment the effect of estrogen in certain body tissues and inhibit it in others. So we'll kind of advance to the next one here. So you can see in different areas, so in the breast, that estrogen effect is inhibited. In other tissues, like in the blood vessels and in the bones, it's agonized. And so you have this sort of mixed grab bag picture of adverse reactions. Those can include common things like hot flashes, night sweats, mood swings. But then we can also have some more serious rare complications, like the risk of blood clots leading to CVA, DVT, PE. And that's because of the agonist effect in the blood vessels, and then also endometrial hyperplasia or cancers because of that agonizing of estrogen activity in the uterus. Typically, we use these in the premenopausal setting and breast cancer setting. But we can also use them as chemoprophylaxis for high-risk women, and we can also use them in DCIS. And then finally, SERDs. So the most common that we're probably familiar with here is fulvestrant or Faslodex, and then the newer FDA-approved elacestrant. And these actually degrade that estrogen receptor to inhibit the estrogen-mediated tumor cell proliferation. Typically, these are more used in the advanced or the metastatic breast cancer setting. Again, pretty common grab bag of side effects related to the inhibition of estrogen. This one can also include some more GI effects, nausea, vomiting, constipation, decreased appetite, can affect the cholesterol levels and the LFTs as well. This is a slide just for review of the common adverse reactions of AI therapies. Another major drug class here is the adjuvant use of CDK4/6 inhibitors in HR-positive disease. This includes palbociclib or Ibrance, abemaciclib or Verzenio, and ribociclib or Kisqali. So based on the MonarchE trial, we saw that abemaciclib, alongside endocrine therapy that we reviewed earlier, lead to improved relapse-free survival for those early stage HR-positive, HER2-negative breast cancers that had a high risk of recurrence. And this, this was a sustained effect after the 2 years of use of these drugs alongside endocrine therapy. These are dosed orally once to twice a day, depending on the agent. Severe toxicities include specifically severe diarrhea with Verzenio or abemaciclib. Typically, that can get better over time, but we really need to handhold and walk with these patients through this, or they can oftentimes just become really frustrated, understandably, and abandon therapy. Neutropenias and anemias are quite common with palbo, and then cardiac toxicities with ribociclib. You can also have fatigue, infections, mouth sores, belly pain, nausea, hair loss, decreased appetite, and more rarely interstitial lung disease. So on to the exciting parts. What is new in the world of HR-positive, HER2-negative breast cancer? Some of the newer agents include antibody drug conjugates. And so what these drugs are is a monoclonal antibody, so an immunotherapy that's actually linked to a chemotherapy drug. And so those two units will work together synergistically. That immunotherapy piece will have basically a site that will recept to a protein on the breast cancer cell and acts as sort of a homing device, and then delivers the chemotherapy agent directly to the cancer cell. So these are kind of pretty elegant uses of these combined therapies. In the case of Trodelvy or sacituzumab govitecan, these target specifically the TROP2 protein on the cancer cell surface. We can use these in the advanced or metastatic HR-positive, HER2-negative setting, especially in women who have already had hormone therapy and at least 2 other chemo regimens based on the TROPiCS-02 study. Really common side effects for these that merits a black box warning is the risk of neutropenias and diarrhea. This can be quite common. And again, as nursing staff involved in patient care, you guys really are the hands and feet, and we rely so much on feedback. So patients aren't always so forthright, especially in a quick office visit. So really getting a sense of, is this patient really profoundly weak? Are they, having more diarrhea than they're really letting on in a way that limits therapy? Those are really important things to identify because there are certain things that we can do to make those more manageable. We can dose reduce, we can delay therapy. There are other drugs that we can add on board. So really important to be, assessing for these things. You can also have hypersensitivity or infusion site reactions, hair loss, decreased appetite, belly pain, nausea, vomiting, constipation, myalgias, as well as electrolyte dyscrasias. Moving on to HER2-positive disease. So fortunately, these are a bit less common, accounting for 20 to 25% of breast cancers. These rely on the human epidermal growth factor gene for growth by making an excess of this HER2 protein with expression of those HER2 protein receptors on the surface of the tumor cell. And those proteins will basically force that tumor to grow and to multiply. So therefore, these tend to be more aggressive, more quickly growing cancers, higher risk of recurrence, unfortunately, particularly in brain metastasis. So the treatment here depends on binding to and blocking that HER2 receptor site so that that signal to grow and multiply is sort of quieted and calmed down. So the mainstays of targets of therapy include really the bread and butter here are monoclonal antibodies. So these are also called targeted immune therapies, and these drugs target that HER2 receptor on the cancer cells and alerts the immune system to destroy those cancer cells. Commonly used agents are trastuzumab or Herceptin, pertuzumab or Perjeta. We oftentimes will use these in combination. There's also an injectable that combines pertuzumab, trastuzumab with hyaluronic acid, and we can use this up front in the neoadjuvant or pre-surgery setting or in the adjuvant setting with chemotherapy for those HER2 diseases that have a higher risk of recurrence or are more locally advanced. Big side effects here that we really have to worry about with this entire class of drugs, these HER2-targeted monoclonal antibodies, is cardiac toxicities. So the myocardium is also lined with HER2 receptors, and so sometimes we can have increase in cardiac strain, we can have decrease in ejection fraction. So again, important points for monitoring are things like dyspnea, dyspnea on exertion, pedal edema, those sorts of things that might let us know, hey, we're developing a problem here. We do have to routinely monitor echocardiograms every 3 months, but just as a patient care standpoint, really important to bear those things in mind. You can also have neutropenias, anemias, infections, nausea, vomiting, rash, myalgias, and some pulmonary toxicities. So again, we'll go back to these antibody drug conjugates, some of the newer kids on the block. So this combines those monoclonal antibodies that we just talked about, those Herceptin, Perjeta, et cetera, that will inhibit HER2 linked to a chemotherapy drug. So that anti-HER antibody acts like a homing signal. It attaches to that receptor site on the tumor cell and then delivers directly the chemotherapy agent. So the couple that we have here are Enhertu or FAM trastuzumab deruxtecan. We can use this in the metastatic or recurrent setting, or if the cancer is unresectable. The kind of an interesting point here is that we can also use these in HER2 low breast cancer. So HER2 gradation kind of comes on a scale, and traditionally the only patients that really qualified for HER2 targeted therapies were those that really expressed abundant amount of HER2 protein. But we sort of have a middle ground of lower HER2 producing cells, and this drug can be quite effective for those also. And then Kadcyla, or T-DM1. So we can use this in the adjuvant non-metastatic setting after they've received chemotherapy before surgery, or in the metastatic setting when they were previously treated with a monoclonal antibody and a taxane-based chemotherapy. Common side effects for these, so we really have to think about interstitial lung disease and pneumonitis with HER2. I would say that's probably the biggest take home. So again, things like dyspnea, increased cough, wheezing, labor of breathing that we really need to be monitoring for with these patients. The cardiac toxicities, again, because we're using those HER2-targeted monoclonal antibodies. We can also have neutropenias, nausea, vomiting, decreased appetite, constipation, changes in LFTs, et cetera. You can have hair loss also with HER2. And then finally, last but not least, triple-negative breast cancers. So triple-negative breast cancer is a tumor that does not express any of these aforementioned tumor markers, so ER, PR, or HER2. This can be a problem because we cannot block and therefore exploit those receptor or those protein synthesis targets as a key point of therapy. Because of that, these tend to be more aggressive, harder to treat cancers that are more likely to recur. Fortunately, these are a bit less common, only about 15% of breast cancers, and they typically can present in younger women, especially Black and Hispanic women, or in the setting of a BRCA1 mutation. Historically, not a ton of options apart from chemotherapy, but newer agents include immunotherapies. So the main player, the workhorse here, pembrolizumab or Keytruda. These are also called immune checkpoint inhibitors. So they bind to that PD-L1 receptor, and they block the immune-suppressing ligands PD-L1 and PD-L2 from interacting with PD-1, and that helps restore normal T-cell response and an immune response. So basically how I describe these to patients is this drug is taking that security guard out of the immune system and kind of unleashing the body's immune system to target and fight those cancer cells. The adverse reaction profile that we have from these drugs is largely related to that heightened T-cell response on, acting on healthy cells that can cause an inflammatory immune-mediated reaction in virtually any body system, unfortunately. So we can have things like pneumonitis, colitis, hepatitis, thyroid disorders, adrenal insufficiencies, type 1 diabetes, nephritis, rashes and other dermatologic reactions, myocarditis, pericarditis, rhabdo, myositis, et cetera. So really checking the lab values here is super important, and just a complete review of systems when we're dealing with these patients. And then finally, those ADCs, the antibody drug conjugates, sneaking up again, that monoclonal antibody linked to the chemotherapy. This one specifically, again, that TROP2 protein that we use in the agent Trodelvy or sacituzumab govitecan. We can use this in locally advanced or in metastatic triple-negative breast cancers per the ASCENT study. All right, and we'll quickly run through, now that we've gone through kind of a brief overview of treatment modalities. And again, I didn't include traditional chemotherapies because I think you all are probably rock stars at those agents. Now we'll move on to a few key updates from the most recent San Antonio breast. So first, women who have an intermediate Oncotype Dx score, we think can safely skip chemotherapy. Oncotype Dx, it's a molecular assay, along with Mammoprint is another common one, at least that my clinic uses. So it is kind of a predictive prognostic tool that we use in earlier stage breast cancers to kind of help identify which women are high enough risk of recurrence that they would actually benefit from chemotherapy. Oncotype Dx specifically is stratified into low, intermediate, and high risk, and traditionally, that intermediate group, we weren't totally sure what to do with. So this Taylor RX trial has 11 years now of data that says these women who have an intermediate risk can skip chemotherapy and proceed with endocrine therapy alone. Secondly, that MonarchE trial that we referenced earlier pertaining to abemaciclib in the early stage HR-positive breast cancer setting did demonstrate that it was of significant benefit for women with a high risk of recurrence, and that benefit extended past the 2 years of therapy that they completed. Thirdly, the Destiny Breast 03 study, this compared those two ADCs that we referenced earlier, Enhertu and Kadcyla, in this setting of metastatic HER2-positive breast cancer, and basically demonstrated that Enhertu offers better progression-free survival than Kadcyla, and probably better overall survival. Fourth, so in one of the earlier slides, we talked about those selective estrogen receptor downregulators, or SERDs. Traditionally, Faslodex or fulvestrant is the one that we've used. The Emerald trial actually showed that a newer SERD, elacestrant or Serdu, actually offers more benefits for those metastatic HR-positive breast cancers. And it was recently FDA approved in January of this year. And we can use that in ESR1 positive mutations as well. And typically, again, these are used in the advanced or metastatic setting along with endocrine, if they failed endocrine therapy previously. These are dosed orally, and again, those side effects, hot flashes, night sweats, you can get some joint pains, LFT elevation, and GI side effects. And last but not least, based on the positive trial results that has been collecting data since 2017, we now think that it's safe for women under the age of 42 to actually press pause on endocrine hormone blocking therapy in the early stage HR positive setting in order to become pregnant. And this did not increase the risk of recurrence. And that is all that I have for today. So if there are any questions.
Do we have any questions?
So when we were talking about like Enhertu and Kadcyla and the risk of interstitial lung disease, and oh, look at that. When we're talking about Enhertu and Kadcyla and the risk of interstitial lung disease and cardiac issues, is there a time frame in where you see those issues come up? Is it like 6 weeks after starting therapy, or is it really just any time?
Typically at least 6 to 8 weeks, but that can happen later on in therapy. So sometimes we'll have a woman who's tracking with normal echocardiograms every 3 months for quite some time, maybe has been on therapy for years, and then we see that ejection fractions start declining. So that's just really the importance of screening measures in these women, and then just sort of being aware globally of those side effects. With those drugs specifically, Enhertu especially, we want to be just thinking in our forebrains about those pulmonary toxicities. Because and again, patients, you sort of have a realm of patients, sort of a spectrum. Some patients that are like what I like to call pan-positive, that will report like everything, and so it's sort of hard to tease through, and then other patients that sort of downplay. So seeing these patients as regularly as you do in the nursing setting, I think you guys have a really excellent clinical gestalt about when someone just isn't quite at their baseline, or when they're maybe struggling to breathe a little bit more than normal, or they're wheezing or coughing and want to chalk it up to allergies. So I would say that's kind of the key take home is be looking for it at any time.
Okay, thank you.
Yeah, of course.
I do have a question from the virtual audience that asks, are there treatment differences between men and women? Do men respond better or worse to the current treatment options?
Ooh, very interesting question. I would say in general, we use really similar agents. So these hormone blocking therapies, oftentimes Lupron is used, so we can use very similar drugs.
Do we have any other questions? Alrighty. Thank you so much.
Okay, thank you guys.